If you were to ask someone to name a piece of equipment used by a doctor or nurse, one of the most common answers would likely be a stethoscope. Doctors and nurses use a stethoscope to listen to a patient's heart in nearly every visit. The sound a heart makes when it beats conveys critical information on the patient's heart health. In this chapter, you'll learn about the anatomy and physiology of the heart, including what to listen for in patients' heart sounds. As a healthcare professional, it's critical that you understand heart physiology so that you can locate and identify abnormal heart sounds. Auscultating, or listening to the heart with a stethoscope, should reveal two sounds during each heartbeat. These sounds are often described as lub-dub and are associated with the heart valves closing. The basic rhythm of the heart sound is lub-dub, pause, lub-dub, and so on, with the pause indicating the period when the heart is relaxing. Understanding the rhythm of the heart will allow you to detect any abnormal heart sounds, which may indicate heart disease. For example, heart murmurs occur when blood backflows or regurgitates through a partially open valve after the valve has closed. In such a case, you will hear a swishing sound when you listen to the heart. By having a thorough understanding of the anatomy and physiology of the heart, you will be able to listen for and identify any abnormal heart sounds so that your patient can receive necessary treatment.
I've mentioned before how our cardiovascular system has a systemic circuit and a pulmonary circuit. The systemic circuit is the one that we all think of, the blue veins and the red arteries. But we really have to think that an artery A goes away from the heart, and a vein goes towards the heart, because the pulmonary circuit is opposite in colors. So the systemic system is the guy that's taking the blood from the heart and going to the tissues with oxygenated blood. Then, after it has dropped off the oxygen in every single little cell, he's picked up carbon dioxide from those cells and he's bringing it back to the heart. So, less oxygen. That's the systemic circuit. But then what? Then we have all this deoxygenated blood that's entered into the right atrium. Now we're going to do the pulmonary circuit. And the right side of the heart is going to send that partially deoxygenated blood to the lungs. So pulmonary artery A away is full of deoxygenated blood going to the lungs, where we're going to take a breath and exchange oxygen, carbon dioxide, get that blood nice and oxygenated again. And now this oxygenated blood is going to go back to the left side of the heart, so the vein is oxygenated, so it's going to be the pink one or the red one. Here's a picture of that flow. So notice the left side of the heart. Look how thick it is. That left ventricle, that muscle is thicker than the right because it's got to send blood all the way across to your head, to your pinky toe. The pulmonary circuit, he is just pumping back and forth to the lungs, so not nearly the same distance, so that muscle doesn't have to be as thick. So this is how it goes. I already said it on a previous slide, but the right atrium is going to be receiving partially deoxygenated blood from all your cells that have made carbon dioxide. The left atrium is receiving newly oxygenated blood from the pulmonary circuit. Goes from the atrium to the ventricle, and then the right ventricle is going to send to the pulmonary circuit, left ventricle is going to send to the systemic circuit. There you go. Important. It gets its own slide. Arteries go away. Veins go toward the heart. So we can't do colors. We have to go away, artery. So let's learn a little bit about this heart. It sits at an angle. It's about the size of a fist, depending on the size of your hand, the average hand. Weighs less than a pound. And it sits actually in the mediastinal space. So we actually don't get into the mediastinum too much, but it's a space between the pleural sacs. So you've got a left and right pleural sac. It's sitting in the mediastinum. And then that guy has his own sac too, the pericardial sac. You've already learned about that in AMP1. This is a weirdo. The base is actually at the top and it points towards your right shoulder. And then it comes down to a point at an apex, pointing down towards your left hip. That pericardium, I'm going to tell you a few more details about that guy now. The visceral layer is the same. It's on the heart. We're going to give it another name now. You can call it the visceral pericardium, but another name for it is the epicardium. The parietal pericardium actually has two separate names. So we're going to break that down into a little bit more detail. The part that is the superficial part, so let's say you just opened up your cadaver and you see the sac around the heart, the outer part, the superficial part, is called the fibrous pericardium. The part that's on the underside surface of that sac is actually the parietal pericardium. So it's the internal side of that outer sac layer. This picture right here shows that outer layer of fibrous pericardium, the underside, which is what you've learned as the parietal pericardium. This part is the parietal layer of the serous pericardium is the part that secretes the fluid. The fibrous pericardium does not. An imbalance, pericarditis. First of all, ouch. Remember, the serous membranes have nerve endings. You can hear this with a stethoscope, and there's nothing you can do about it. It hurts when your heart breathes. You have to figure out what's causing the inflammation of that pericardial sac, but it's very painful. Cardiac tamponade is when that pericardial space fills with fluid. This is an emergency. It can happen for different reasons, but sometimes you can't know what caused it. So sometimes it's just a mystery, and that's called idiopathic. Whenever something happens and you can't solve why it happens, you just need to keep it from ever happening again. It would be one of those things where if a patient showed up and you were suspicious, all that pressure from the fluid pushing on the heart will cause you to throw arrhythmias. They'd x-ray you and they would see a giant basketball in your chest. So they would tap the fluid out and try and figure out, what caused it. Maybe based on the fluid or other sort of signalment. Okay, so the layers of the heart wall, you have that visceral pericardium, which is called epicardium, epi on top of. Myocardium is muscle, muscle. And we're going to talk about the way that those muscle fibers bundle. And then you actually have something called the cardiac skeleton. It's a whole bunch of connective tissue. It's not muscle fibers. It's anchoring the muscle fibers, and it's helping to support the valves, some of the vessels, And he's also going to be kind of a barrier for the zapping, the electricity, the action potentials that are going to pass through the muscle. So here you go. Look at how we have this swirly, whirly, almost figure 8 kind of appearance to the muscle. And what this does is when these muscles contract, it's going to start at the apex of the heart, so at the point of the heart, and it's going to contract starting there, and it's going to ring the heart like a mop. So starting at the bottom, it's going to kind of twist as it contracts, and then unring the mop as it relaxes. Ring the mop, contract, unring the mop, relax. The cardiac skeleton, you can see how these, let's see here, how these valves right here are not made of muscle. They're made of a connective tissue right there. This picture is also showing some of the connective tissue of that cardiac skeleton. I don't worry about the different names of these connective tissue. It's just showing you a picture so you can appreciate why it's called skeleton. The innermost layer is simple squamous epithelium, and we talked about this in AMP1. Endocardium is that lining of the vessels. It's continuous. It's all the vessels and the heart. It's the entire cardiovascular system is layered with this simple squamous epithelium. This part you probably already know. You have left and right atria, left and right ventricle. They're divided by a septum. When a baby is growing in utero, his lungs are not inflating. So he's actually getting all of his oxygen from the placenta. So the lung tissue does need oxygen supply, but because that organ is not in full working order yet, it doesn't need as much as it would as, a baby that's been born or a person. So there's actually a pulmonary bypass, which is a hole in the interatrial septum. And the hole is called the foramen ovale. And then once a baby is born, it should be closed, and it's going to be called the fossa ovalis. This picture, you're going to get so tired of it. You do pretty much need to memorize all of these different parts of the heart. So we're going to have blood flow. Get my little pointer here. So this is superior vena cava, so we're getting some deoxygenated blood from the head. And this is the inferior vena cava, so this is deoxygenated blood from the rest of the body. It's all going to come and dump in the right atrium. We're going to flow through the right AV valve, also known as the tricuspid valve. And then what's going to happen is that heart rings like a mop. That blood is going to go up and out. It's going to go past the pulmonary valve, and it's going to go into the pulmonary trunk, into the left and right pulmonary arteries. This way and this way. The lungs are going to oxygenate that blood, and that blood, so A away, notice that the pulmonary arteries are blue. So A away, they're going to oxygenate it. Now the pulmonary veins are going to come back. You have 4 of them. So 2 coming from this way, the left side, and 2 coming from the right side, but they're all going to here. All of them coming to here from around the back side. Can't see it on this picture. All going to dump into the left atrium. Left atrium to right atrium through the mitral valve, also known as the bicuspid valve. I'm fine with right AV valve, which is right atrioventricular valve. And then as that heart rings like a mop, it's going to go up through here, through the aortic valve, and this, like this. So from lab, we'll have mentioned some of this. We have a coronary sulcus that is a groove that goes between the atria and the ventricles all the way around, like a crown. Coronary sulcus. We have another little indention that goes on the anterior side of the heart, the anterior interventricular sulcus, which carries the anterior interventricular artery. That guy is called the widowmaker because if that one blocks up, if that vessel gets a blockage, so much of the heart muscle gets deprived of oxygenated blood that it's pretty common to die from that blockage. And we also have another one on the posterior side of the heart, posterior interventricular sulcus. So here we go. So in the coronary sulcus, coming through right here, and coming around right here. And then this is showing a picture of the anterior interventricular sulcus with the anterior ventricular artery right there. This is the posterior surface. So we still have that sulcus that's coming all the way around like this. And then here's the posterior interventricular sulcus with the posterior interventricular artery. The atria are the receiving chambers. So as the blood is returning back to the heart, it is doing a large amount of just filling, and it's only going to contract at the very end of its filling. He doesn't do a whole lot of pumping, in other words. We have these little ear flaps on both of the atria. They're called auricles, and they're just adding extra volume to the atria. So, I've mentioned 2 of the veins that dump into the right atrium, but we have a third one. It's called the coronary sinus. So I said the superior vena cava is draining blood from the head. It's actually doing all the areas above the diaphragm. And then inferior vena cava is coming from regions below the diaphragm. But a third one, the coronary sinus, is deoxygenated blood from all the coronary veins, and it's going into this big old pocket, and then we're going to have a pretty small hole in the right atrium for that. Because the heart also supplies itself with oxygenated blood supply, and those cardiomyocytes are making carbon dioxide. So it's all going to drain into the cardiac veins, which is going to dump into the coronary sinus, which is going to dump into the right atrium. And I've done the left atrium already, receiving oxygenated blood from the lungs. There's 4 of them, 2 from each side. So here we go. I'm looking to see if they even have on here if they've labeled the coronary sinus entering into here. Am I blind? I just don't see it. Okay, so the guys that do the majority of the squeezing are actually the ventricles. When you look at the anterior surface of the heart, you're really seeing mostly right ventricle. The posterior and inferior surface is the left ventricle. We have some papillary muscles that are have strings. So you've heard of pulling on the heartstrings? Those are chordae tendineae. So the papillary muscles are on the inside of the ventricles. They look like little nipples, and a cord that's going up to the AV valves. So these chordae tendineae, these heartstrings, when the papillary muscle contracts, then it's going to pull on those heartstrings and tighten the valves closed during ventricular contraction. This would be a great slide to help you study for lab. Actually, all the pictures are. So again, the ventricles are the guys that are doing most of the work, the squeezing. They're the actual pumps. Ventricle muscle is definitely thicker than the atria, and the left ventricle is definitely thicker than the right ventricle, because the left ventricle is going to the whole body, the systemic circulation. I need some blood down at my pinky toe. The right ventricle is just pumping to the pulmonic circuit. So that's just going lateral to the heart. The right ventricle, like I said earlier, it's going to push blood with the ringing of the mop kind of in a superior direction into the pulmonary trunk, which is going to separate into right and left pulmonary arteries. And then the left ventricle is pumping into the aorta, which is the largest artery in your body. Told you you're going to get tired of seeing this picture of the heart. This is showing the fossa ovalis, so you can see kind of an indention on this heart. I would say for the lab test, it's more likely to be a picture of the model because this is too nondescript for a picture. But that would have been a foramen ovale in a fetus because the lungs aren't working. So it's a bypass. This picture also would be excellent to study for lab. Notice here's a little, this is real, right? This is a sheep heart probably. And papillary muscle. I don't know, I guess it could be a human heart. I don't know. And this papillary muscle has these chordae tendineae, which is the heartstrings, which are holding on to the tricuspid valve. On this side, papillary muscle, chordae tendineae, and you can't really see the valve, but it's right in here. The AV valves stands for atrioventricular valve, so it's the valve that's going between the atrium and the ventricle, and when the ventricle squeezes, we want to make sure that none of it goes back up to the atria, right? We want it to leave the heart. So the valves control that. When the blood leaves the left atrium, the first vessels that leave out the aorta are actually going to be the left and right coronary arteries. It is most important to make sure that the heart muscle gets oxygenated blood. So on this one, you can see the right coronary artery coming out. Where am Right here, right here. And he's going to be giving blood supply to the heart. Then it's going to come up and do some more branching with the brachiocephalic trunk, the left common carotid, and the left subclavian artery. This guy's going to branch too. We're going to do a lot of branching. Those valves that I was talking about, the aortic valve and the pulmonic valve. So the pulmonic valve is going up to the pulmonary trunk. The aortic valve is going up to the aorta. The name for those guys collectively is the semilunar valves because they kind of look like moons. There are no valves between those major veins that are returning back to the heart, so going into the atria. So superior vena cava, inferior vena cava, coronary sinus. There's no valves there. Pulmonary veins going into the left atria, no valves. Because in general, by that point, blood pressure is pretty low. So we don't want backflow, but if we're not pushing hard, there shouldn't be that much backflow. So here you can see the reason that the AV valve on the right is called tricuspid is because he has 3 leaves. The mitral valve, also known as the bicuspid valve, only has 2 leaves. And then these guys, they kind of look like they're little pieces of a moon. There's a real one right there. So the AV valves are keeping blood from going from the ventricle to the atria. The chordae tendineae are like the anchors to the valve that are trying to prevent any backflow, so we don't want those valves to evert, right, to blow out like an umbrella in the wind. We need them to stay closed, and so the chordae tendineae help with that. So let's talk a little bit about those valves for a second. When blood is coming back to the atria, it's going to be pushing on the AV valves. And the pressure from the blood returning actually causes those AV valves to open. It's like blood is coming into the atria, but it's also trickling into the ventricles. So they're just kind of hanging there limply. Limply? Yeah, limply. There's the word, limply. But at the very end, once it's gotten its final fill, then the atria are going to squeeze that last little small drop, not all of it, but it's going to do its best to get almost all of that blood into the ventricles with a final squeeze. And then the ventricles are going to start to squeeze. And when the ventricles start to squeeze, all the valves are shut initially. When the atria is filling, the pressures are the highest in the atria. So the leaves of the valves can actually kind of be pushed on too. Okay, now with the AV valves closed and the ventricle just starting to pump, actually initially, both valves are all closed. Just briefly, and this is going to be isovolumetric contraction. So all the blood is staying in the ventricle just briefly until the pressure gets high enough in the ventricle, and then the ventricles are going to start to squeeze the blood out of the heart. The semilunar valves also prevent backflow from going from the major arteries back into the ventricles. They open and close in response to pressure. Again, each valve kind of resembles a half moon. That's how it gets its name. And the pulmonary semilunar valve is between the right ventricle and the pulmonary trunk. The aortic semilunar valve is between, or you can call it aortic valve, that's fine, between the left atrium and the aorta. When you have a good enough squeeze from that ventricle, it's going to open up those semilunar valves. And then, as the ventricles relax, those semilunar valves are going to close because of a back pressure. Kind of like the booger buster that, let's think about this, that you would use on your child. When you squeeze it, it pushes air out. But when you release it, it sucks, right? Sucks the snot out. Well, we don't want the blood to come back into the heart. So we have to have a valve to keep that from happening because the pressures are high. So things that make a heart tired. Those valves are loosey-goosey and you have backflow. Or those valves get stiff. Or maybe you're even born with just a very small space, so you're born with them stenotic. So the heart has to work too hard to get the blood past the flaps. We can fix these things. So I've already said this once. You definitely need to memorize the flow of blood through the heart. You're going to have blood return from the body, superior vena cava, inferior vena cava, coronary sinus, with deoxygenated blood. Go from the right atrium through the tricuspid valve, also known as the right AV valve, going into the right ventricle. Then it's going to pass through the pulmonary valve or the pulmonary semilunar valve into the pulmonary trunks, go into the left and right pulmonary arteries into the lungs. Then, after the lungs oxygenated, so we're in the pulmonary circuit, we're going to leave the pulmonary circuit and we're going to return back to the left side of the heart through the mitral valve, also known as the bicuspid valve, also known as the left AV valve, into the left ventricle, through the aortic valve, into the aorta, into systemic circulation. First hole in the aorta holes is for the left and right coronary artery. We need to make sure that that heart gets oxygenated blood. Cool pictures. Whenever blood is going to the left and the right side, because this is all happening at the same time. At the same time, the left atrium's getting blood, so is the right atrium. It's always the same amount of blood. In other words, it's a double pump. And here we go. Equal volumes of blood are pumped to both circuits at the same time. The pressures are different because the lungs, they're just right there. They're just lateral to the heart. The systemic circuit, it's got to go all the way down to your big toe. It's got to get all the way to the top of your head. So that's why the left ventricles, the myocardium of the left side is thicker than the right. It's got more pressure. It's got more work to do. This is a cross section. You can see the difference on this, the difference in the thickness of the myocardium on the left side. So let's talk about that coronary circulation. So we've done systemic circulation and we've done pulmonic circulation, but the heart muscle needs oxygen too, or else it's not going to make it. So this is the oxygenated blood and the deoxygenated blood to the heart muscle. You're going to have a left and right coronary artery. It's going to be the first thing that leaves the aorta. Now, we've got these arteries are going to go through the coronary sulcus, and they're going to have junctions, anastomoses. So that, what does that mean? That if one little part of the heart gets blocked, one little branch gets blocked, then hopefully you're going to have an alternative route to make sure that that muscle gets blood supply. So some branches that you need to know. The left coronary artery goes into the left interventricular artery. It also branches into the circumflex artery. And you'll see this in lab. You probably already have seen it in lab by now. The right coronary artery is going to branch into the right marginal artery. So both of them R. That's what I do. That's just me. You do what you want. And then the posterior interventricular artery, which is going to go into that posterior interventricular sulcus. So here's the picture showing this. Here is the, there we go. The right coronary artery is going to have this marginal artery right here. And this guy is going to keep going around the back side of the heart. So this is an anterior view. So we're pretending like the heart is see-through here. And this is the posterior interventricular artery. But since it's an anterior view, you can see the other one pretty well. Well, some of it. Left coronary artery, see this is where it's coming off of the aorta, right there and right here, left side. You're going to have the circumflex artery, which is going to go around towards the back, and then you're going to have the anterior interventricular artery on the anterior side. Flip it over. Oh, not yet. We're not going to flip it over just yet. Coronary veins. So all of those cardiomyocytes, those muscle cells, are also making carbon dioxide. They're going to go into little veins, which are going to finally end in a big kind of a pocket called the coronary sinus. And that coronary sinus is what's going to go into the right atrium with its deoxygenated blood. So the veins that you need to know are the great cardiac vein, which is running in the anterior interventricular sulcus. The middle cardiac vein, which is running in the posterior interventricular sulcus. And then actually there's a small cardiac vein that's running with the marginal artery. So here we go. This is an anterior view. So the great cardiac veins running along the anterior interventricular sulcus. And then we have the middle cardiac vein here running in the posterior interventricular sulcus. This is on the back side, the posterior side. And then we actually have this small cardiac vein right here running along the right lateral side of the right wall. This is a posterior view. So here is the posterior interventricular sulcus with the middle cardiac vein. And notice it's coming in here and it's dumping in this balloon kind of thing. All of the veins are. That's the coronary sinus. And that's what's going to dump into the right atrium also, so that it can take that deoxygenated blood to the lungs to get reoxygenated. Here's the great cardiac vein. So he's doing this little circle right here, coming back from the front side, right? From the anterior interventricular sulcus area and dump into the coronary sinus. Angina, you've probably heard of angina. As we get older, sometimes those chest pains, send us to the hospital, and they say, no, you didn't have a heart attack, but you're having angina. So, is a warning sign, perhaps? People that get angina a lot are on medicine. We're trying to prevent a heart attack. The name of a heart attack is a myocardial infarction. Infarction is a blockage of blood supply. And then, of course, muscle, heart muscle, myocardium infarction. Blockage of blood supply to the cardiac muscle. You can't replace that guy. He doesn't go through mitosis. It's going to be replaced with scar tissue, which doesn't function. If it is a massive heart attack, too much of the myocardium was destroyed and you die maybe instantly. If it's a small amount, then you could live to see another day. If you have repeat heart attacks, you end up getting enough scar tissue, even if they're small, that it's going to put you into heart failure. Repeat from A&P1. Cardiac muscle cells are striated. Remember how the actin and myosin lay down. They're not long like skeletal muscles. They're branched. They have 1 or 2 nuclei. They have, do you remember intercalated discs? They have that. They have lots of mitochondria because that muscle is very, very, very busy. The stripes, of course, are caused by the overlap of actin and myosin. So has sarcomeres. Let's talk about those intercalated discs. What are those? Those are where cardiac cells come together. And it's very important that our heart muscle cells stay stuck together. So we have those zippers called desmosomes. Do you remember that? The intercalated discs are made of desmosomes and gap junctions. And do you remember gap junctions? Those are little spaces between cells, like little tiny holes that allow things to pass from cell to cell. The reason that this is important in a heart is we need every heart muscle cell to beat at the same time. If heart muscle cells don't beat at the same time, you get fibrillation, right? You get wiggly jiggly heartbeat. We need it to go lub-dub, lub-dub. So we need that electrical signal to pass through every single heartbeat every single heart muscle in sync, so that you can have lub-dub, lub-dub. So it can act as a pump, not a wiggly jiggly mess. Okay, intercalated discs. So on this one, they kind of stain purple. Sometimes they stain pink, but aren't they pretty? So inside an intercalated disc is both gap junctions and desmosomes. To make sure that those myocytes stay physically stuck together, they're zipped. Desmosomes look like zippers, and gap junctions allows things to pass from cell to cell. And so we need that electricity to pass from cell to cell so the heart beats in sync. Here's a picture of microscopic anatomy of the cardiomyocyte. Lots and lots and lots and lots and lots and lots of mitochondria. You do still have some T-tubules. They're wider. There's not as many. There's no triads per se. And we're going to get our calcium from the sarcoplasmic reticulum, but we're also going to get it from outside of the cell. So we're going to have calcium. Actually, extracellular calcium is what's going to trigger the release of the sarcoplasmic reticulum's calcium. So what's the same? We're still going to have a depolarization that causes that muscle to contract. We're still going to have the traveling down the T-tubules, although we don't have as many. We don't have a triad. And we are still going to have some calcium from the sarcoplasmic reticulum. We're still going to have the whole sliding filament, and we're still going to have contraction that way. But cardiac troponin is very specific to the heart muscle. So when somebody has a heart attack and they're measuring troponin levels, they're specifically measuring cardiac troponin, because if you have a heart attack, so you block off some blood supply to the heart, then you are going to kill some of the cells. So when you kill a cell, it releases, it comes apart, including little troponin molecules. Now it's floating around in your blood. So they'll measure a series of troponin levels and see if it's going up. Here's something super cool about the heart. It's magic. It is. Those myocytes that I was talking about, they don't have anything on a few little cells that are hanging out in the heart. They're called pacemaker cells. And the pacemaker cells that are in the heart, they don't contract. They create their own electricity that tells the heart to beat. They create the action potential that makes the muscle contract without any help from the nervous system. Now, if you get scared, the nervous system can change your heart rate, make your heart rate go up. Or if you're feeling super mellow, it's going to be in a low, just a regular rate, which is based on the pacemaker cells. But the electricity that makes the heart go comes from pacemaker cells. When the heart beats, because of those intercalated discs in the gap junctions, the heart beats as one. So it's called, the whole unit as a pump is called the functional syncytium, but you know the term in sync. That's where that comes from. So it's a very effective pump. It has calcium that is going to trigger contraction. We're going to have some calcium from the outside of the cell is actually what's going to trigger the release of more calcium from the sarcoplasmic reticulum. So first, we're going to have some slow calcium channels in the cell membrane. So remember sarcolemma, cell membrane, which allows calcium to come down into the cell, and then that's going to cause the sarcoplasmic reticulum to release intracellular calcium. So if you remember, skeletal muscle doesn't use extracellular calcium. It all comes from the sarcoplasmic reticulum from an action potential that travels down those T-tubules. Because of the way that this happens, your heart can't go into tetany. You remember that term from A&P1? Skeletal muscle can go into tetany. That would be bad for a heart. So that absolute refractory period where you absolutely cannot re-stimulate a skeletal muscle fiber is kind of short. But for the cardiac muscle, the absolute refractory period is almost as long as the contraction. So we end up not being able to cause that frozen state of tetany in the heart. The heart cannot use glycolysis for ATP. It must have oxygen. He has more mitochondria than even that crazy long skeletal muscle fiber. The heart can use other fuels, but he must have oxygen. Comparison. I mentioned this one earlier. We have different forms of troponin, but the one to the heart is very specific. So when you have somebody getting their troponin levels checked after they've had chest pains, they're specifically checking to see if any of the heart muscle cells have let go of their own troponin. So that specific heart troponin, and then they're going to check it again, repeat, and see if that troponin level is rising. So let's say they draw some blood, they find some cardiac troponin, and they retest it in whatever, an hour or 2 hours, and that value is going up, they're going to diagnose a heart attack.